Welcome to the SIBO Doctor Podcast with Dr. Nirala Jacoby, a US-trained naturopathic physician and director of SIBOtest.com, an online breath testing service and education portal for practitioners. In this podcast series, medical experts join us to discuss functional digestive disorders, clinical practice, and research as it relates to small intestinal bacterial overgrowth and associated conditions. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. If you're a practitioner and want to learn more about SIBO, head over to the SIBOtest education portal where you can sign up for courses, masterclasses, and group mentoring sessions to expand your knowledge for successful treatment outcomes. If you're a patient, please know this information is not intended to diagnose or treat a medical condition. Please ask your doctor before initiating any new treatments. And now, over to Dr. Jacoby and the SIBO Doctor Podcast.
If you're like me, you're finding that treating small intestinal bacterial overgrowth can be complicated. Patients often present with a myriad of symptoms and associated conditions which require holistic thinking and a methodical approach to treatment. This podcast was born out of a desire to start a conversation with other practitioners, educators, experts, and researchers, and see if their insights can give us new treatment considerations, especially for our difficult cases. In this podcast series, our guests talk about functional gut disorders, hormonal issues, the enteric nervous system, food intolerances, the immune system, the microbiome, methylation and genomic issues, and everything else that can make a SIBO case very confusing. I believe that by understanding the often complex interconnection of SIBO with other disease manifestations, we can be more effective in our treatment approaches. I hope you find this podcast useful in your practice, and thank you for listening. Welcome, SIBO practitioners, to another episode of the SIBO Doctor Podcast, and I'm really delighted to have Dr. Lenny Weinstock with me today. We've sort of met up a few times over the last 4 years at different conferences, and it's always such a pleasure, and I consider him a friend, and he's a wonderful human being that's doing a lot of amazing work in the field of SIBO. He's board certified in gastroenterology and internal medicine, and is also the president of Specialists in Gastroenterology and the Advanced Endoscopy Center, teaches at Barnes Jewish Hospital, and is an associate professor of clinical medicine and surgery at Washington University School of Medicine. Additionally, he's a primary investigator at the Sundance Research Center and has actually written more than 80 articles, abstracts, editorials, and book chapters. He's very passionate about SIBO and its connection to different conditions like restless leg syndrome, rosacea, talks a lot about LDN. So I'm very, very happy to have Dr. Weinstock here with me today. Welcome, Lenny.
Thank you, Nirala. So nice to hear your voice again.
We just met in Chicago, actually, where we had a wonderful time with our colleagues. And so one of the things that we do on the podcast is sort of a conversation about what you're finding in your practice, because you obviously have a very specialized center where you treat a lot of SIBO. So a couple of questions for you in terms of what your relapse rate is after rifaximin, because many practitioners have actually heard Dr. Mark Pimentel mention this issue around relapse rate may also be hastened by adhesions, meaning that the relapse rate is faster after antibiotic therapy when somebody's had adhesions versus not having adhesions and just using rifaximin, that the relapse rate is something like up to 3 months, if not longer. So I wanted to kind of start off the conversation before we dive into the nitty-gritty of the restless leg syndrome and other conditions. So what are you thinking about that with relapse?
Well, I was actually going to pull up an article that I wrote in 2011, Digestive Disease and Science, which is posted on my website. So if you want to go there, www.gidoctor.net. That's gidoctor.net. And there, what happened was, it's kind of an interesting background, but it really looked like Xifaxan or rifaximin was going to be FDA approved for IBS-D in 2011, and everything was said, everything was great. Pimentel study, which I was involved in as one of the research sites, looked like it had a great statistical difference in terms of efficacy after 2 weeks with follow-up in the first 12 weeks, especially over the next 4 weeks, and showed statistical difference between placebo and rifaximin, where rifaximin kept people in remission on average 3 months. But the key thing was that it was remarkably better, improved symptom relief, and decreased bloating. And that was the first time large numbers, 1,200 people were studied to show the difference. And then the FDA decided, well, that really worries us. You know, we're going to give an antibiotic. How likely is it that you're going to develop resistance? Are the relapse rates going to be significant and serious? And so it was then that they said, nope, couldn't do it. So Pimentel looked at his numbers retrospectively. I looked at mine retrospectively and published it. And I'm going to pull that up in a second. But all along, I've always believed that in the chicken and the egg phenomenon. And the situation there is that something triggers bacterial overgrowth. You don't suddenly pop, oh, I've got bacterial overgrowth. There's got to be a reason why it occurs. And we know now, of course, that there are several different ones. And I think we'll talk about what I call autoimmune irritable bowel syndrome. But we know of anatomical reasons. We know the classic reasons in textbooks for small intestinal bacterial overgrowth to recur, you know, with poor motility in the setting of scleroderma or pseudoobstruction. We know of surgical reasons, blind loop, and we know adhesions are actually becoming an increasing role in relapse of SIBO. But the big predominant finding is that we've got an autoimmune phenomenon going on where we lose our migrating motor complex because antibodies are formed, the so-called antivinculin antibody, and that damages the myenteric plexus nerves, which then disappear, and with it goes the migrating motor complex, and then the bacteria either go up through the ileocecal valve, or of course they're in the ileum, or go up from the terminal ileum higher up, or you infect yourself with your own colonic bacteria by ingesting it by poor hand washing. So anyway, I have always used preventative therapy, prophylactic therapy. I just didn't believe in treating and just watching and waiting, except in, of course, I was doing a study where that's all you could do. So I looked at 70 patients who had what I called an adequate response to rifaximin, significant relief based on my clinical notes and patient reporting. And then I looked at the patients who had had one or more more than one retreatments. So they had 2 or more treatments, and that was 70% or 49 out of 70 patients. And I looked at them over 3.5 years on average, with a range going from 3/4 of a year to 6 years. And then so what we did was looked at the numbers, looked at what treatment they had as well. And virtually all of them had concomitant therapy, 91%. At that time,
so that would have been rifaximin and like a prokinetic is what you're saying, or?
Right, okay. 91%. So Tigacerod, which is Zelnorm, which was taken off our market, 13. Erythromycin, low-dose erythromycin, 45. And naltrexone, low-dose naltrexone in 26, and probiotics in 20. Because there was some data that Bifidobacter could stimulate the migrating motor complex.
Yeah, I think Bifidobacterium lactis HNO19, is that the study you're talking about? That one Bifidobacter,
yes. Yeah. So, I looked at the patients, and basically 49% had retreatments, and an average of 2 retreatments was required over a mean of 3.8 years. Now think about it. So they had basically 2 retreatments. Therefore, 3 retreatments total over 3.8 years. So a little bit more than a year it lasted. And Pimentel looked at this earlier on and said that on average, his patients treated with Tigacerod lasted a year. His patients treated with erythromycin lasted 9 months. Recurrence is common, but it's dissipated. Whereas, as you stated and inferred earlier, that if they took the rifaximin, they would fail after 3 months on average. And when I looked at my retreatments, I was able to get patients into remission after each retreatment, up to 6 retreatments. And, thus in my population, I did not see resistance. And that's what the Target 3 study showed, where it looked at 2,600 patients, and everybody got open label rifaximin, of course, at that time, and 38% stayed in remission for 18 weeks or more. So that's more than 3 months, obviously, and so you do see these patients who get into deep remission, but I like, in light of how difficult it is to get the rifaximin, I like to cement it in with prokinetic therapy, where I think they're likely to have abnormal migrating motor complex.
So you don't actually see patients very often that very quickly relapse after treatment?
I do see some, and either the people who tell me they felt better while they were on it and they relapsed 2 weeks later, I think maybe it's a placebo response, or some of those patients have extraordinarily high hydrogen levels, and then I'm starting to think much more these days about biofilm issues covering the bacteria. Yeah, so that is a concern.
So you wouldn't, just to clarify, so your first thought is that the rifaximin you may need to do another round of rifaximin rather than assessment for potential adhesions. Because, like what I read about adhesions, just read a study the other day about just any sort of intervention, surgical intervention abdominally, whether that's cholecystectomy, etc. They found adhesions on every single patient after any sort of intervention. But do you think it's as frequently an issue in your practice?
Well, if I get a patient who has the classic symptoms history followed by symptoms, namely they have classic post-infectious irritable bowel syndrome, I feel very comfortable saying, okay, that's a person who likely has autoimmune IBS. That said, there are some individuals who have no history, and of course, probably that's in the 80% range, where they don't remember any recall of any attack of food poisoning, no matter how you explain it to people. And sometimes you have to spend a couple of minutes giving them examples of what food poisoning is. I take a history of their surgical history, and then I start worrying about it if they've had like a perforated appendix and they've had intermittent problems since then. It's certainly not classic med school training. We're taught, episodic small bowel obstruction are the symptoms of adhesions and nothing else.
Interesting, yeah, because now what we're learning is that it's pretty common, I guess, to have these adhesions. But if you're testing pretty much the antivinculin or antivinculin antibodies on everyone that might have SIBO, how frequently are they positive?
So when I was doing it, I was getting a rate about 45% or so, which then gets you into the situation, okay, if it's not that, what is it? So you have to open your mind. And that's where I'm finding, some concerns about other motility disorders, like through postural tachycardia, postural orthostatic tachycardia syndrome, POTS, which could have a prevalence in our country up to 3 million.
Really?
1 to 3 million, and compare that to Crohn's, which is 1.6 million. So, I think it's not commonly found. Ehlers-Danlos, that's another big one, I think. So I had a patient referred to me by Dr. Pimentel because she went to Washington U, the undergraduate college. I saw her and treated her for SIBO, and she kept on relapsing. I could not figure her out, didn't respond to anything. She went back to see him, and when he examined her, he found signs of Ehlers-Danlos with hypermobility syndrome, and then did a small bowel follow-through with upright views showing a droopy, loopy small bowel, and that was almost acting like a blind loop, and that's why she kept on getting infected, reinfected, because she basically had an area where there was a sewer, just didn't move, and the bacteria multiplied.
Makes a lot of sense. We've heard a lot about Ehlers-Danlos in the last few conferences. How often, I think it was it one of the presenters who said it's as common as celiac disease so about, what is it, also like 3%. Is that what you just said?
So
or was that about POTS? Yeah.
There's a review where it said it could be up to 2% of the population. And I had a patient that I wrote up a case report where she had Ehlers-Danlos, diagnosed in retrospect, which caused obstructive sleep apnea, which can cause inflammation. It also caused SIBO, and this was on top of an chronic complex regional pain syndrome. And when we treated both conditions, plus giving her LDN for pain relief, all of her symptoms went away, and it was a dramatic change from 8 years of severe pain to absolutely normal life since the treatment. Yeah, it was incredible.
So getting back to POTS, we'll sort of loop to restless leg syndrome, but you and I have had conversations about POTS because it is something that I am actually seeing more frequently. So I'm wondering, what's its connection to, if there is a connection to SIBO in terms of dysautonomia, or, is there some connection there? And also what your thoughts are on why the prevalence perhaps is increasing.
Okay. Well, it is associated with the HPV vaccine. That's given more and more. So that pregnancy, Lyme disease, other viral infections have been associated with. But just to think about HPV, it wasn't around 15 years ago, but now it's given out like candy to women and now young men too. So that is one thing, because I think a lot of it is autoimmune. And it's easily suspected, if you will, when people say, well, if you ask people, well, do you feel dizzy or lightheaded with standing? And they say, yes, I often do. And as did a patient today who had, however, been diagnosed at Mayo for this condition. And she had Ehlers-Danlos, which was suspected. And she actually had mast cell activation syndrome, which nobody suspected. But clinically, she has so many symptoms of this condition. Where the mast cells are active and release chemicals and give people lots of symptoms. So, some of the fibro patients we see probably have mast cell activation.
Yeah, we had a podcast with Heidi Turner. She did a great job at the last the Chicago
Yes.
Integrative Conference on RA, but she actually did a great podcast a while ago, last year, I think now, here on mast cell activation syndrome. So, but I didn't know that there was, you had told me this before, but our listeners don't know this about the connection between POTS and mast cell activation syndrome. What's the connection there?
Well, for some reason they're tied together.
We don't know yet what it is.
We don't know yet, except for the possibility that T cells that are involved in POTS could be triggering activation of mast cells. Also, there is a microbiome change with mast cell activation syndrome, and perhaps in POTS, there's microbiome changes there because the motility is abnormal. You think about sympathetic hyperdrive, which is what POTS is all about, and you can have very slow small bowel action. In fact, this woman had chronic bloating and pain, especially with fiber, suffered terribly with that, although when she controls her diet, she's really not terribly symptomatic, but her motility of her small bowel was dramatically abnormal. And when you're reversing peristalsis by not letting the vagus or the parasympathetic be active, you're paralyzing it. And the sphincters tighten up, and so you have pelvic floor dysfunction, which this patient did today. And so I've been looking for small intestinal bacterial overgrowth in my patients with POTS, and I have this study that's being submitted for publication. But the data is that of 27 of my patients who had a breath test, and I have about 35 POTS patients in my practice, the breath test was abnormal in 69%. Now, not always classic high hydrogen. Some of them were methane plateaus, but definitely abnormal in 69%. And when I gave antibiotic therapy, and it could have been rifaximin or could have been other antibiotics that we use for SIBO, it helped the GI symptoms in 10 out of 15 and helped the POTS symptoms in 4 out of 15. And,
I have a 15-year-old. I have a 15-year-old right now with that had been, I'm not sure if it was the right diagnosis, but he'd been diagnosed with POTS and lots of other issues, has digestive issues and a lot of sort of gastroparesis symptoms. He never had a gastric emptying study, but they just sort of gave him domperidone. All his POTS symptoms disappeared. I just did a SIBO, a breath test on him, and he is positive, even though, not as positive as I would have liked to have a glaring case, but he is positive. And but that was, he had just briefly stopped the domperidone for the purpose of the testing. So he probably would have been more positive had he not been on it. But yeah, his symptoms were much better with that. So there definitely is something that, the other thought I was having as you were speaking is, went to a really interesting conference last weekend where one of the presenters talked about Parkinson's, and what now some of the evidence is showing is that the vagus nerve is actually the highway for some of these peptides that are traveling up and depositing certain things. Can't remember now the name of this polypeptide, in the brain, and that goes on for years before diagnosis. So I'm just postulating about whether or not there is some similar issue when you talk about microbiome dysfunction, LPS, and other endotoxins that are potentially traveling through these nerves. Is that a potential, or is that a wise sort of thought to have?
Interesting. It wasn't the anti-synculin.
No, or
Yeah.
sirtuin. No, it wasn't that. I
yes,
think it was the.
yeah.
I'll find it. I should have probably thought about it
Okay.
before, but no, it was absolutely compelling what they were talking about. So there's a lot of stuff that we're going to be seeing, I think, in the next few years that connects a lot of the dots that we've, as naturopathic doctors anyways, have always, we've been treating the gut for centuries. So this is not anything new for us to make these dots, but to actually have it validated is really very gratifying, actually. So, because even with Parkinson's, and we always treat the gut, whether that's SIBO or other issues. But moving on, I am getting off on
Sure.
a tangent,
Go ahead.
which I am prone to do. So let's kind of talk about our restless leg syndrome, because I loved your lecture in Chicago because it finally sort of really explained it to me like it never did before as to exactly why some patients with SIBO have RLS. So, and the connection with hepcidin. So can you talk about that a little bit?
Okay, well, let's talk about what restless leg syndrome is, because it is often confused, but it's the compelling urge to move, often with discomfort in the extremities. Usually the legs, can be the arms, but it's the urge to move while you're awake, and generally when you're resting, in the evening, and it worsens at bedtime, and when you get up and walk around, the discomfort and the urge goes away. Of course, you're moving, so you have to keep moving for this goes to keep it away. Otherwise, when you lay down, it comes back. It's not the foot tapping, and it is not specifically the jerking, kicking, moving movements while you're asleep. That's periodic motor limb disorder, which can be correlated, of course, with restless leg syndrome. But this is while you're awake, and it's a challenge for patients because it prevents them from going to sleep. The pain can be quite something to deal with, and recently narcotics have been used for restless leg syndrome because it's actually fairly effective. So, why do we get it? You want to know?
Yes.
Yeah. Well, if we really knew, we'd cure it. But there are theories in terms of the pathophysiology. The most predominant one is that there's central nervous system iron deficiency. And we can talk more about that. There can be an abnormal dopamine system in the brain. You can get it because of peripheral neuropathy. I've demonstrated that small intestinal bacterial overgrowth can cause it, and treating it can help. We think that inflammation can play a role because so many of the diseases have inflammation. And in a study that I did on Crohn's disease and my own experience, when patients have inflammatory bowel disease and it's active, you treat it, they get better. And this may tie into hepcidin, which we'll talk about. My research partner, Dr. Walters, is concerned that immune disorders could be involved. And then he has also studied endorphin deficiency in the brain. And so those are the main 7 things that could relate to explanations. You were concerned about hepcidin.
Yeah, as it relates to, with SIBO having an elevation of TNF alpha and IL-6 and LPS, all of which trigger this protein from the liver to be increased, which then stops the iron absorption from the small intestine. And so I just wanted to kind of talk a little bit more about that and what your experience with iron infusions then is. And my thought was also, isn't iron can be a substrate for bacteria. So I'm wondering if hepcidin is also upregulated to prevent any sort of iron absorption potentially. For I mean, is there a reason why the body would do that? You know, that's sort of, I always think about why things are happening. So if there is an infection, in other words, SIBO, would it be wise for the body to say, okay, upregulate hepcidin because I'm detecting that there is LPS, etc., plus hepcidin of just my own quick research into it. Isn't it also itself and sort of antimicrobial peptide that can actually be elevated in infectious diseases? So just wondering, if that's another connection.
Well, the basic issue is that it is a hormone that regulates iron absorption. That's, the basic definition. And it has been found in autopsy studies that there's more hepcidin in the brain of people who have restless leg syndrome. And mice actually are shown to have circadian rhythms in CNS iron, which is interesting and might be a clue to nighttime RLS symptoms. But when mice are given inflammatory triggers, LPS in particular, hepcidin level goes down. Hepcidin levels go up. And also, they start getting hepcidin production along the coverings of the brain. And so that hepcidin in a local area could, in fact, cause decreased transit of iron across the choroid plexus into the brain. And by doing so, that might explain why there's less iron in the brain. Now, sometimes we'll find patients who have low iron because they're losing it through menstrual periods or pregnancy, and you give it back to them and they get better. If you just take all comers who are treated with IV iron and they have iron deficiency, 68% have a very good response to this treatment with restless leg syndrome, but obviously not 100. So something else is going on, and this is where I think there's a role for endorphin deficiency, which has been shown by Dr. Alpers in another autopsy study where they looked at metenkephalin and endorphins in the brain versus control autopsy patients. And with that, he showed a difference, statistically significant difference between endorphin levels. And it's shown that endorphins protect the dopamine function in the setting of iron deficiency. So it could be that you need there's two hits going on. Something is destroying the endorphin cells that are producing endorphins. There's the opioid cells in the brain are affected for some reason. Could it be due to an autoimmune phenomenon? It's possible. Normally, we're not supposed to get antibodies to cross the blood-brain barrier, but multiple neurological diseases, including restless leg syndrome, are associated with increase in the permeability of the brain, blood-brain barrier. So that's kind of interesting.
With your treatments then, if you have a restless leg syndrome patient that tests positive and doesn't necessarily respond completely to rifaximin, in other words, still has RLS, do you then give LDN to them? And what's the response rate with that?
So I give every RLS patient naltrexone, everyone. I'm a big believer in it, and I also check their vitamin D level and their ferritin, and I give them iron to get the levels up. Now, I don't know. I mean, you said some intriguing things about bacterial vectors and iron, and I'm not quite sure. I don't know enough about that to make a comment. But let's just go to the way I treat. So I looked at, I did 2 studies, retrospective studies, chart review, which were augmented by interviews with patients when the data was not present. And so when I treated 40 patients, I had 40 patients who were treated with rifaximin followed by LDN. There was a marked response in 21 out of 40, moderate out of 5 out of 40, slight in 3, and none in 11. So 65% had marked to moderate response, which is very good because some of these patients were on therapy or had failed other therapies. And when I treated patients who had breath test negative curves with LDN, it was just a handful, 7 patients. 57% were in the marked to moderate responders. And many of these patients have been treated for a prolonged period of time, average of 107 weeks, now up to 7 to 8 years for some. It's not an easy drug always. I had a 15% dropout in the 40 patients because of side effects. And unfortunately, that occurred whether they were in the relatively low dose of 2.5 or the higher dose of 4.5. A second study, just briefly, looked at 25 patients in the last year, and 40% had marked to moderate response to rifaximin alone, and a 58% response to the naltrexone that followed it. So these were, again, SIBO patients who were treated with rifaximin and LDN, but with the questionnaires, I dissected the two and just said, okay, which modality resulted in what response? And so just LDN by itself that followed the rifaximin was 58% efficacious. And then I used monotherapy in 12 patients, and there was a 50% improvement in these patients to the marked to moderate response. So it's pretty cool.
That's very significant, huh? That's great, those responses. When we think about low iron and restless leg, or let's say when we think about SIBO, and many of my patients just have anemia that just doesn't respond to oral iron supplementation. Do you think that's also worth looking at in terms of, is that potentially due to hepcidin being upregulated, and therefore no amount of oral supplementation or meat eating is helping these patients to get their iron levels up?
That is starting to be looked at by a group in Pennsylvania. So they're just initiating discussions, and they've asked me to weigh in and give them some advice. And so I just started talking with them, but it is interesting. They want to see if they can overload the body with iron with Injectafer and see if that increases things. I mean, you got to think about the patients with renal failure who have elevated iron levels, but they respond to IV iron, and so because of all the inflammation, their iron levels are high, but they still are truly iron deficient. And so it is kind of interesting. So they get high intravenous doses of iron, 750 milligrams, and they can respond even though their numbers don't quite look like it. So maybe it is that hepcidin, at least in the restless leg syndrome patients who don't have renal failure, that's being a big driver of iron deficiency in the brain. So.
Yeah, because you also mentioned that some some cases of RLS are related to or have elevated CRP as well as an underlying, or maybe not underlying, but a concomitant issue that might be relevant in their cases. So, one of the things with iron infusions that I've seen, and I'm just curious if you see the same thing, is like it seems to have sort of like a pro-inflammatory effect for a brief period of time in some patients, and it'll sort of highlight what I've seen in quite a number of my patients. They feel really rotten for a few days, and either they have joint pain or they have areas of inflammation, and certainly not universally with iron infusions, certainly not, but in some cases I do see that. And I just wonder if you also see that.
Sometimes. Yeah, I wouldn't say all the time.
Okay. Maybe just a little higher prevalence here, because I wondered if that's due to ferritin being acute phase reactant, or if there's some hidden source of inflammation. But we can drop that since you don't see it that often. Okay.
Yeah, I see the ferritin more with like rheumatoid arthritis or Crohn's disease where it's elevated, but SIBO patients I don't see it elevated, which is curious.
Well, this was more general statement for not so much with SIBO. Yeah.
Okay. All right.
And I myself have actually experienced that. I sort of had severe reflux after I got an iron infusion, and it's sort of like a little weak spot for me, And the fact that it was just like full on for 2 days or so was just, I found that curious because I'd heard it from other people, but. We may just be weird up here in the Northern Rivers in that regard. So we'll just drop that line of questioning at this point. Okay, so I think we've got a good understanding right now that there are the connection between RLS and SIBO being hepcidin, being upregulated, therefore no iron is absorbed from the small intestine, and therefore we have areas in the brain that have low iron. And when you then correct it with iron infusion and endorphin support with LDN, you get dramatic responses. Is that a good summary?
I think that's basically true, and or that there's transportation into the brain is reduced directly. So with possibly hepcidin production occurring locally in the brain, and that's affecting iron transport. We don't have proof of that yet.
Is there anything that blocks hepcidin? Is that being investigated?
Ooh, interesting. I don't think. Well, nothing's being investigated in that area.
So the idea is just to completely overwhelm it, and just with iron infusion.
Right.
Yeah.
Right.
Okay.
Yep. And look for any underlying reasons why there's inflammation and treat it. So you do such a great job with herbal therapies and natural remedies to heal gut lining, and I've been adapting that for quite some time with zinc and L-glutamine and ultimately probiotics and some. So you want to treat whenever you can to heal the gut.
Well said. Very well said. Quick, because you just jogged my memory on the outcome of that study where you used 3 arms of different prokinetics, and you mentioned Bifidobacterium lactis as a potential motility agent. So what was the outcome of that?
I would have, that was not dissected thoroughly for me to be able to pull those statistics right out of that paper. It was really just general prokinetics. So it just, I do see some patients who say they don't want to be on drugs, and we put them on Bifidobacter infinis, which is we have readily available, infantis. And I've seen some winners there that they, come back after a year and a half or 2 years saying, having my first relapse. And I'm saying, okay, all right, let's recharge you. But, who knows whether they would have done it without, but I think just looking at most patients, they probably had a good response. If somebody has a very high level of hydrogen in the breath test, I'm going to be more aggressive in using prokinetics and or now treating with biofilm therapy, especially if there's a long history of GI problems.
And you use the Biosolve PA. I think I've heard you say that on the SIBO Summit, the talk that you gave there, the Biosolve with the bismuth subnitrate and DMPS and alpha lipoic acid, I think it is.
Yeah.
Is that the one? And you getting good responses with that?
I haven't used it enough to be able to say how much it's made a difference, and I haven't done a scientific study on it. I've also used NAC, so we're going to see how that. There's some data for that anyway that Mike Ruscio presented showing Helicobacter, showing slides of it, slipping off the film off the Helicobacter to get better therapeutic effect. So I thought that was cool.
Yeah, that definitely is a great therapy to use with H. pylori. But yeah, I often also think, and anyways, I'm going off on a tangent with biofilm, but it is so fascinating to just see what other practitioners are doing and what the results are, because it is important that people understand what's working and what's not working. That's really the whole sort of ethos of this podcast, so to speak. I just, to kind of get some ideas out there rather, because there's so much information on the internet that people are, we all have them, the patients that come to us and say, I read this and that, and there's just no evidence for that. And so I'm always trying to clarify things. Now, in that vein, just want to kind of get your take on what Dr. Pimentel talked about in terms of that we have these three types of IBS or SIBO in terms of IBS-D and IBS-M, which we now think are mainly SIBO, and then we have IBS-C, which is the methane predominant type, and it's now sort of some groups are thinking that that's actually a separate condition, and I've talked about it before with other practitioners because I've sort of suspected that for some time. In cases not where we see methane still rise in the 60 to 90 minutes, but where methane is high and stays high all throughout the test, sort of implying that this is more colonic bacteria that's been just producing methane. Well, it's one organism that produces the methane, but that is contributing, even with the proper prep diet, etc., that it's just so prevalent in these cases that it's more it's less SIBO and more sort of a, I don't know what to call it, but it is more large. LIBO. It's LIBO and SIBO together. Well, SIBO is really where I think of this fermentation that's happening. And one of the interesting things that he also mentioned, however, in this talk was that was actually the global outreach that they did back last year, where they talked about how when you have very high methanes, that really does skew the rise of hydrogen in the first 60 minutes. So we're none the wiser in a way, because on one level, if you have high methane that stays high, it could have skewed a hydrogen rise. So it's still possible to be SIBO. And I'm just trying to figure out if these people need to be treated differently, if we need to include more fiber, if we, I do a lot of bowel retraining in these very recalcitrant kind of constipation types. So just kind of want to get your take on that.
Well, if the methane's high in the beginning and it's what I call the methane plateau, then I just think it's colonic source of bacteria, because especially if it doesn't rise at all, well, you're giving the methane bacteria something to eat along the way. But if it's not going up, it's not the small bowel, and we know that methane slows the colon down, and likely factors into constipation by a direct mode of action. Now, whether it actually is causing Pain is another question altogether, because the visceral hypersensitivity and decreased motility are the basis of IBS-C. So, and yet, can it be treated with antibiotics? Can it be treated with fecal transplant? Can it be treated with an herb, a trantal that directs hydrogen away from the methane producers? I think those are all three good things to think about. The FDA treatments for IBS-C are, chloride channel activators, which force chloride and bicarb and then water into the colon to hydrate it. But it doesn't address, perhaps this toxic effect by the methane-producing bacteria. Certainly, antibiotic therapy can help. I wonder if a good study could come out to say, okay, perhaps in some of these individuals where you want an antibiotic to be water solvent, you should use metronidazole and neomycin in these patients as opposed to rifaximin, which is more addressing the small bowel. So those are some of my initial thoughts.
Are you still using, I guess what I'm asking is, are you treating them different from, obviously it's going to be different from hydrogen, that's clear, but do you always, in high methane, use rifaximin neomycin combo, for example? Because we all know that the methane producers, they're just harder to treat. And sometimes when they've had 20 years of constipation, their response rate is not always directly proportionate to methane reduction. So, or do you see that? Do you actually see it being proportionate to methane reduction?
I often do. Not always, but often do.
It's not always that gets me,
Yeah, and then you've got the patients with the 4 or 5 methanes. I don't believe in blasting them with antibiotics in those patients. I'd rather try a trantal or probiotics to see if they respond first.
There actually was a very interesting, in my talk to Dr. Jason Horlak, who is a big proponent of pre and probiotic use in certain circumstances, and he did present compelling evidence at the last SIBO Summit. But in this last podcast, he mentioned a new probiotic, well, it's not new, but it's a probiotic called BioGaia, and it's L. reuteri protectis that has shown, albeit it's a small study, but it's shown in one study a 50% reduction in methane. So it's like a baby colic formula. So I'm just mentioning it here because I want other people to try it, because it seems like the dose is very reasonable. It's not mega dosing with probiotics, and just to see if we get further reduction in methane, because I find that methanogens are difficult because you get mixed results with Atrantil, you get mixed results with everything I use, whether that's garlic or a whole number of hosts of herbs. I'm now experimenting with myrrh in its early days with that. But it is one of those things that for me, it's not hard to treat hydrogen dominant SIBO. It's more the methane. And when I test these patients, because I do a lot of stool testing for functional digestive issues, and it includes a PCR DNA of those bacteria, and Methanobrevibacter is always present in that stool sample. So we know it's in the colon as well. So anyways, I just thought I'd mention that because it was a tiny clinical pearl from someone I respect very much that could potentially be beneficial for those methanogen producers.
So this is Gaia.
It's called BioGaia, and it's actually a Nestle product.
I heard of it a long time ago.
Yeah, so it's a baby colic formula, and it's called BioGaia protectis. And we're just getting it through a distributor, but apparently it's not hard to find if you just go to biogaia.com. It's I think the Swedish manufacturer is, and it is a small study, so we need a bigger study with methane, but that should be easy, an easy study. Because if you're only using, and it's something ridiculous like 100 million colony-forming units twice daily. That's 5 drops twice daily. So that was the dose they used in this study. So, I think it dropped it not like 100 to 50. It was more like 20 to 10. But it's significant if you're only using one product. So worth to try it out.
Interesting.
Okay, well, all right. I'm going to use my opportunity that I have an eminent sort of a gastroenterology with me. I'm going to just ask you a simple question that I've often pondered, and I've asked other gastroenterologists about this in terms of this issue about the ileocecal valve being chronically open and allowing bacteria to enter from the large intestine into the small intestine. So when you do a colonoscopy, how often do you actually see the ICV be open? Or is it a rare occurrence?
It's usually closed, and I'll sometimes see prolapse, and I'll see the first centimeter, but it's not gaping. Now, when it's gaping and patulous, then you think this patient has chronic ulcerative colitis, which is one of the findings there. Interesting. And some of those patients can get this flattened ileum, who have backwash ileitis with ulcerative colitis. But honestly, you don't see it. Now, you're looking at a snapshot in time. You're not staying there for a half hour watching it. But there is, and it's a sphincter, and all sphincters give up and relax. So, there's potential. And that's why, if you do cultures of the terminal ileum, you're going to find 100 million bacteria, colonic bacteria there. It's not sterile. So the ileum has a place where bacteria go. So it must relax enough to get bacteria and stool back up, but not to a great degree. You usually don't find stool. When I do an ileoscopy, you see mucus and bile, but you generally don't see stool.
Thank you. Lenny, this has been great and just wonderful to get your take on some of these questions I've had, and just to have a conversation. And really appreciate the time that you've given me here today.
My pleasure.
Take care.
All right, thank you.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Head over to our sponsor, SIBOtest.com, an online testing service for your patients and home of the Practitioner Education Portal. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.